Hello, good day everyone. Today I'll be talking on multimodality imaging in diagnosing dementia and MCI. So as an overview, I will be covering what is the definition of dementia, the role of imaging and interpretation of dementia, which include MRI, brain perfusion imaging, 18F FDG PET-CT, amyloid imaging PET-CT, tau traces in PET-CT, and share with you some case vignettes. So what is dementia? Dementia is an insidious onset and gradual progression of impairment in one or more cognitive domains. And for major neurocognitive disorders such as Alzheimer's disease, there should be at least two domains that are impaired, along with the evidence from serial mental status examinations. Neurodegenerative dementias involve the shrinkage of neurons and loss of synapses. It involves cortical tauopathy. These are diseases such as Alzheimer's disease, frontotemporal lobar dementia, and Lewy body dementia. Another major neurocognitive disorder is vascular dementia and mixed AD. So the pathophysiology of Alzheimer's disease is contributed by some genetic aberrations along with concomitant metabolic conditions. Patients with traumatic brain injury, sleep apnea, or diabetes or hypertension may accelerate the process from normal cognition to developing dementia. This process takes several decades to form and involves the formation of amyloid beta monomers, amyloid beta oligomers, and the phosphorylation of tau proteins, which are in the axons of the neurons in the brain. With hyperphosphorylation, these microtubules deteriorate and are damaged. And so this involves neurodegeneration in the long process. Dementia has been detected in a study by Brack and Brack that did autopsy of brains of Alzheimer's disease patients in varying stages of the disease. In the beginning stage, amyloid plaques and tau phosphorylated tau proteins are detected mainly in the entorhinal cortex, which then progress to the hippocampal region and medial temporal regions of the brain. As the disease progresses, it involves the parietal regions and proceed to involve the rest of the neocortex. So we can actually use in vivo imaging to diagnose AD in a non-invasive way. MRI will depict hippocampal atrophy, and in longitudinal scans, we can see the progression of hippocampal atrophy. There will be loss of the normal configuration of the hippocampus in late stage with expansion of the CSF spaces surrounding the hippocampal region. However, these are late features of AD. We can actually use nuclear medicine imaging to detect Alzheimer's disease at an early stage. Brain perfusion imaging or SPECT-CT using technetium-99m, hexamethylpropylamine oxime or HMPAO, or technetium-99m ethyl cysteine dimer ECD SPECT imaging can be used to evaluate the cerebral perfusion and regional cerebral blood flow. Reduced cerebral blood flow can be detected in the posterior parietal region, medial temporal lobes, posterior cingulate, and the precuneus in Alzheimer's disease. 3D stereotactic surface projections can be used to better demonstrate the regional reduced cerebral blood flow or hypometabolism that occur in PET-CT. The transformation of SPECT or PET-CT images into standard stereotactic orientation, reducing the combined effects of the brain atrophy, is the benefit of the 3D SSP projections. There are 8 standard surface projection images which include the left and right lateral surface of the brain cortex, the left and right medial surface, superior surface, inferior surface, and anterior and posterior surfaces. These surface projection images are then compared with reference images from inter-subject comparison. Z-scores will be calculated, which are the voxel normalization to global mean or cerebellar values. The Z-score is the control mean minus the individual value divided by the control standard deviation. And these are displayed as overlays on tomo sections. Software packages with 3D SSP function include Hybrid Viewer from Hermes Medical Solutions, Cortex ID by GE Healthcare, Neurostat 3D SSP by University of Michigan, USA, and SPM by Wellcome Department, UK. Brain perfusion spec can be used to evaluate MCI patients who are potential converters or non-converters to AD. In this particular image, patient A has marked reduced cerebral perfusion, therefore demonstrating high Z-score values, characterizing decreased regional cerebral blood flow, as you can see, involving the temporal and parietal regions. The scan after 3 years demonstrates increased values of Z-scores, indicating further reduction in regional cerebral blood flow in the regions involved. And this kind of pattern demonstrate that SPECT imaging can predict converters of MCI to AD. In this patient B, there is minimal reduced regional cerebral blood flow. Therefore, there is no significant, there is not much significant reduced regional cerebral blood flow with low Z-scores in the temporoparietal region, and they do not show marked changes or worsening in the scan done 3 years later. A research that I did with my supervisor in the UK, Prof. Shoban Minjamuri, is on the role of PET-CT amyloid imaging compared with technetium-99 HMTOO SPECT imaging. The image here in panel A demonstrates technetium HM-pulse SPECT CT scan with diffuse hypoperfusion in the temporoparietal lobes. And the amyloid scan shows reduced cortical gray-white matter contrast, indicating extensive beta amyloid plaque deposition. This pattern of imaging indicates that the patient has probable Alzheimer's disease. As opposed to patient in panel B, this patient had multiple foci of hypoperfusion on SPECT imaging, as evidenced by reduced perfusion in the frontal region, in the posterior and anterior parietal regions, and temporal regions. However, on the amyloid scan, there was no significant beta amyloid deposition, and this pattern indicated that the patient may more likely have a vascular type of dementia. 18F-FDG PET-CT can depict glucose metabolism within tissue with decreased activity. It identifies regions of neuronal dysfunction and degeneration. It acts as a marker for neuronal loss. The indications for 18F-FDG PET-CT in patients with memory loss include for the assessment of progressive dementia, for distinguishing between AD and other neurodegenerative conditions, and for the assessment of neurodegeneration in subjects with MCI before the onset of clinically diagnosed dementia. Non-specific for disease identification, 18F-FDG imaging requires a review of structural imaging to rule out other causes of cerebral hypometabolism, such as cerebral infarctions. However, it is good to identify the patterns of reduced FDG metabolism that may point to the diagnosis of dementia. A study that I conducted with my collaborators at the Center for Diagnostic Nuclear Imaging in University Putra, Malaysia, is a voxel-wise analysis of 18F-FDG metabolism in correlation with various presentations of Alzheimer's disease and Alzheimer's disease continuum. These are surface projections of cortical FDG metabolism, with the green color coding indicating normal FDG metabolism in a cognitively normal elderly patient. And the black color coding is approximately 4 standard deviations from the normal FDG metabolism in the brain. And for the dark blue color coding, it indicates 2 standard deviations of reduced SUV max from normal population atlas. The green is the normal SUV max of FDG metabolism in the brain, and the red indicates regions of 2 standard deviations and above, indicating FDG hypermetabolism in the brain. So as you can see, for MCI patients, there is a beginning of a reduced SUV max indicating FDG hypometabolism in the medial temporal regions, which then progress in mild AD to be more severe, and the regions extend from the medial temporal regions to involve the posterior parietal regions. And in severe AD, the rest of the neocortex is involved and demonstrate extremely reduced FDG metabolism. There are typical characteristic features of FDG hypometabolism that can be seen in various subtypes of Alzheimer's disease, which include AD, dementia with Lewy body subtype, and frontotemporal dementia, which can be frontal or temporal subtypes of lobar FTDs. For FDG hypometabolism patterns in AD, there is FDG hypometabolism at the temporal parietal association cortex. As you can see, the red indicates severely increased Z scores, indicating FDG hypometabolism. So in these regions of temporal parietal regions, there is a characteristic pattern of Alzheimer's disease FDG hypometabolism. In dementia with Lewy bodies, it has some similarities with AD, where there will be temporal parietal region involvement. However, in DLB, there is an additional occipital region involvement with initial sparing of the posterior cingulate cortex in DLB, which gives the cingulate island sign. For frontotemporal dementia, there will be, especially in the frontal subtype, there is extreme reduced FDG metabolism in the frontal regions and also the temporal regions. And there will be marked reduction in the temporal regions in FTD of the temporal subtype. So there will be actually relative sparing of the parietal cortex in FTD. 18F-FDG in dementia with Lewy bodies have the sign and symptoms of fluctuating cognitive function with spontaneous Parkinsonism and recurrent visual hallucinations. Cardiac iodine 123 MIBG scans may reveal characteristic features of DLB, whereby there will be decreased cardiac sympathetic innervation due to degeneration of noradrenergic nerve fibers, and therefore controls would have good cardiac uptake of the MIBG radiotracer, but in the DLB patient, there is absence of cardiac uptake. And on FDG scans, we can see reduced metabolism in the temporal parietal regions and occipital regions, with relative sparing of the cingulate cortex, indicating the cingulate island sign. For amyloid PET-CT imaging, it is a radioactive PET-CT diagnostic agent for the estimation of beta amyloid neuritic plaque density in the brain. A positive scan increases the likelihood of having dementia of AD type, and the absence of amyloid deposits in the brain using this scan makes the diagnosis of AD unlikely. However, a positive scan is non-specific and does not establish the diagnosis of dementia or AD. MEBIT or flow beta pair was utilized to conduct the imaging dementia evidence for amyloid scanning IDEA study, a partnership by Eli Lilly and Company and the Alzheimer's Association. The IDEA study using amyloid PET-CT imaging identified significant change in the patient management process. Example, there were changes in AD drug therapy for controlling the symptoms, other drug-related therapy, or initiated the need for counseling about the safety and life planning for patients with dementia. However, without a disease-modifying drug therapy, having the PET amyloid scan may not lead to significant changes in overall patient outcome. Therefore, the IDEA study is now proceeding with the phase 2 to find out if it can influence patient outcome. Here we can see a normal amyloid scan with good preserved gray-white matter cortical contrast. There is good gray-white matter differentiation. Whereas in these abnormal scans, there is excessive deposition of beta amyloid plaques in the cerebral cortex with poor gray-white matter differentiation. A review that I conducted with my supervisor, Prof. Shoban Wijamuri, regarding 18F flow beta amyloid PET-CT of patients. Here we can see this patient having a fused hybrid PET-CT image, and here the grayscale amyloid PET image indicating no significant beta amyloid plaque deposition. The MRI brain of this patient in T2 weighted imaging showed no evidence of significant cerebral infarction. With the history of multiple cardiovascular risk factors in this patient with deteriorating cognitive function, the diagnosis of vascular dementia was so more likely because of the absence of amyloid deposition on the amyloid PET scan. Carbon-11 PIB is a radio tracer that can also be used to detect amyloid deposition in the brain. And here, for the patient with the loss of cortical ribbon and poor gray-white matter differentiation, this indicates a positive amyloid scan. And for the preserved cortical ribbon indicating a good gray-white matter differentiation, this indicates a negative scan with nil or insignificant amount of amyloid deposition in the cerebral cortex. Now we go on to tau protein PET-CT radiopharmaceuticals. The first generation tau tracers include 18F AV1451 by Eli Lilly and 18F THK5351 by Tohoku University, Japan. Physiological uptake, which is off-target binding due to monoamine oxidase B, was seen markedly in the first generation tau tracers. These occurred mainly in the basal ganglia region, in the thalamus, and in the brainstem. Localized retention of the tracer in the medial temporal lobe without amyloid pathology would indicate primary age-related tauopathy or PAD. In AD, there will be high retention in the medial temporal lobes, posterior cingulate regions, and the precuneus, and in the basal frontal lobe regions. There will be low retention in the cerebellar cortex. For second generation tau tracers that include 18F RO948 by Roche, 18F MK6240 by Merck, and others, have very little off-target binding and are more specific for the tau protein tracer in detection of dementia. Increased tauopathy also correlates with worsening cognitive impairment. Now I would like to share with you some case vignettes of patients that I came across. during my fellowship training. A 57-year-old woman with progressive memory loss had SPECT imaging using HMPAO and fused 18F flow beta PET scan and grayscale 18F flow beta PET scan were done for this patient. The projections indicate certain regions of hypoperfusion on SPECT imaging, and this amyloid scan, can you interpret what would be the likely diagnosis for this patient? Yes, this patient had reduced perfusion in the regions that were typical for Alzheimer's disease, at the temporal and parietal regions, with some scattered foci of reduced perfusion in the anterior parietal region. There was also some left anterior frontal region hypoperfusion. But the PET amyloid imaging did not detect any significant amyloid deposition with good gray-white matter contrast. Therefore, with no obvious evidence of beta amyloid plaque disease in this patient, a diagnosis of vascular dementia was made. The next patient is a 74-year-old male with a history of short-term memory problems and gradual memory decline for some time with a query of dementing pathology. This patient had amyloid scan and was correlated with the MRI of the patient. This is a T2-weighted MRI image. Can you predict what is the diagnosis for this patient? Yes, this patient showed marked amyloid deposition in the brain cortices with poor gray-white matter differentiation. And the patient's MRI showed age-related atrophy of the brain and in the temporal regions with age-appropriate dilatation of the lateral ventricles with minimal deep white matter hyperintensities on T2-weighted imaging, but no evidence of marked cerebral infarction. In this patient, the diagnosis was to be probable Alzheimer's disease. The next patient is a 68-year-old female patient with speech difficulties and deficit in memory with visual spatial disabilities. The SPECT CT HMPAO was performed for the patient and amyloid scans were performed for this patient. So can you tell what was the diagnosis for this patient? Yes, this patient had asymmetrical, heterogeneous, reduced perfusion in both parietal and temporal lobes that were worse on the left side. And there was normal areas of temporal perfusion that were noted in between the abnormal parietal and frontal regions. Some preserved areas. And these findings indicate patterns of cerebral blood flow commonly seen in patients with mixed dementia, which is Alzheimer's disease along with vascular dementia. This patient had significant beta amyloid deposition in the cerebral cortexes, and the diagnosis was mixed dementia. Finally, I would like to conclude by saying that multimodality imaging increases the specificity of making the diagnosis of Alzheimer's disease and other dementias. Imaging, however, is not a standalone diagnostic tool and needs to be interpreted hand in hand with clinical history, physical examination, and neuropsychiatric testing. Current knowledge classifies AD as a predominantly amyloid pathology with tau pathology occurring as a secondary event, and neurodegeneration as evidenced by FDG scan, hypometabolism, and brain atrophy noted on MRI as a late stage biomarker, as evidenced by the ATN criteria, A standing for amyloid, seen on either CSF biomarkers and amyloid PET scan, T standing for tauopathy, seen on CSF biomarkers or tau radio tracers on PET imaging, and N neurodegeneration as seen by MRI imaging criteria. However, there is work in progress as immunohistology, due to its increased sensitivity, can detect tauopathy as preceding beta amyloid deposition. There is time-dependent trajectories of protein aberrations that occur in the brain that need further research to identify biomarkers that can help in the understanding of the disease process. Cerebral amyloid accumulation occurs several years before functional 18F-FTG detected hypometabolism and structural changes and may precede the symptoms. I would like to acknowledge my collaborators in my research involving Alzheimer's disease. I conduct my research at the Center for Diagnostic Nuclear Imaging at University Putra Malaysia and at Hospital Pengajar UPM, University Putra Malaysia. And also to acknowledge my supervisor, Prof. Shoban Binjamuri from the Royal Liverpool and Broad Green University Hospitals, NHS Trust, Liverpool, UK. Here I'm attending the National Radiology Conference in UKRC in 2016. And here my fellowship at the hospital in Liverpool, sponsored by the IAEA, and with my supervisor, Prof. Shoban Binjamuri. And I was very honored that my supervisor visited the center I work in University Putra Malaysia. And we had a very a nice sharing session and an educational event at the university, and which was attended by Professor Dr. Maurizio Dondi, who was at that time the section head of the Nuclear Medicine Division in Human Health IAEA Vienna, and he was previously from the University of Bologna, Italy. I would also like to acknowledge the team at the Integrative Brain Imaging Center in Tokyo, along with my supervisor, Professor Dr. Hiroshi Matsuda, the director of the Integrative Brain Imaging Center in Japan. Here, along with the team who attended the regional workshop on nuclear medicine applications, SPEC and PET, in the diagnosis of neurological conditions in the National Center of Neurology and Psychiatry at the Integrative Brain Imaging Center, Tokyo, Japan, under the IAEA RAS 6091 project in 2019. And with that, I would like to thank you for your attention.